Good evening, namaste. Most difficult task to have the last presentation of the day, and that too after the stalwarts in the day have spoken about safety, about quality, about communication, coming straight from Dr. Reddy. Such a wonderful session, and I have the most difficult task speaking about nursing attrition and impact on quality. Friends, who knows it better than the nursing leaders sitting here? Who knows it better than the hospital administrators sitting here? We all dread the word attrition. Every day when you go for any meeting on quality, patient safety, any other meeting, all you hear is this went wrong, that went wrong, and why did it go wrong? And the answers come from doctors, answers come from the nursing leaders, the comments come from the administration. We have so much of nursing attrition. Long time back I read a book, Who Took My Cheese Away? Here, as nursing leaders, we say, who took away my nurse? Or who took my nurse away? And why? We fear the word attrition in nursing. Look at this, the grim reality of attrition. Major issue impacting the performance, the profitability of the hospitals, and for being profitable, for having an impeccable image for efficient and effective patient care, we need to have a fully engaged, a completely efficient and stable team of professionals who have got maximum touch points, who are the largest workforce. Say about 55 to 60% of the team in a hospital belongs to nurses. And they have the maximum touch points. As it was pointed out in the previous session, it is the nurse who has to spend maximum time with the patient, who also has to bridge in the gap for herself, for her supervisor, for the nurse manager, for the doctors, and at times for the administrative staff who is supposed to interact with the patient. If this workforce is not stable, not motivated, not inspired, and is fast moving like an open-ended pipe, people coming in and people moving out, imagine what goes wrong. I do have a large presentation which I don't think I will go through every slide because of probably 30 or 35 minutes given to me, but I'll still do justice to this important topic because the youngsters sitting here need to take a few lessons. They impact the attrition in the hospital, and the senior leaders sitting in this forum get most impacted because their function gets impacted. So let me try to do justice to this important topic. It impacts patient and family experience. As we said, a nurse has to make a bonding, a rapport with the patient while the patient is still in the hospital, and more so for patients who come for repeat experience, patients coming to the dialysis unit, patient coming to the oncology unit for a chemotherapy, patients with chronic disease coming back and back. If they find a different nurse at every visit, if they find a different face, it becomes so difficult for the family and for the patient to connect, to explain, and to build trust with each visit. It impacts the recovery time of the patient for the same reasons. A new nurse in every shift or every day has to be oriented to the specific needs, to the culture, to patient's behavior, to the disease requirements. Hence, it definitely impacts the recovery time. It also increases the length of stay. Now you would ask me why? Having a different nurse, how can increase the length of stay for a patient? Can somebody answer me this? Any young nurse, a fresh nurse, a junior nurse, how change of a nurse can increase a patient's average length of stay in the hospital? Okay, when a nurse is new or when a nurse changes every now and then, when there is large attrition, there is increased burnout. Nurses are under stress because somebody is absent, somebody is new, somebody is not trained, and more work, more burden is taken by the group who's available. And when there is stress, there is burnout, there is exhaustion, there will be more deviations while a nurse is working, and she may be under pressure of not following the policies, the processes, or the protocols as important as common as the hand hygiene. She's under pressure. She's running from a patient to another. Maybe she's not yet remembered to wash her hands, or she has not remembered to change her gloves, which leads to a hospital-acquired infection, which leads to complications for the patient, and hence the average length of stay, the bill of the patient has all gone up. So imagine increased nurse attrition can do so many adverse things in the hospital. All of us know it impacts quality of care, it impacts patient safety. We just spoke about hospital-acquired infections. Financial cost of losing a single nurse. I came across this while I was trying to look at some data on attrition and the impact of attrition. So imagine what is the impact of losing a single nurse, calculated to equal about twice the nurse's annual salary. Probably here, the hospital administrators and the nurse leaders need to take a cue. If that is the cost of losing a nurse, and if we are losing a nurse because of some percentage of money to her annual salary, instead of losing an already trained and qualified nurse, why not add that money to the nursing financial component? That's something to be looked at. So what happens here? Losing critical you will from the hospital, and that too from nursing attention or quick and timely response. At least he or she will speak to about 27 people the negative comments, and hence the hospital would lose at least satisfied patient. Also, there is a reverse to it. If a patient goes back home happy and satisfied with the care and attention, by positive word of mouth, he will bring in about 9 more patients, 9 new patients to the hospital. Hence, it needs to be really considered with so much of seriousness that how the increasing attrition or higher attrition in a hospital can impact the profit and loss statement of the hospital largely. There are contingent costs because of the nursing turnover. And what is the contingent cost? There are more accidents, there are more needle stick injuries, there can be accidents in the operating room, a wrong patient being shifted to the operation room, a wrong patient or a wrong part operated. There can be less attention to the set and defined protocols. So if the attention is missing because of shortage of people or because of overworked people, everything can go wrong at all places, which leads to a tarnished image of the hospital in the community, in the society, and patients lose trust. More than patients, doctors lose trust. And if I know of some examples where our star performer doctors would get very upset when a well-qualified and trained nurse has moved out of his department and she's leaving or she's left. All he says is, stop her. Now for the nursing leader, that's quite a challenge if the nurse is moving overseas. And believe you me, in India, we lose our cream to the overseas. We lose our best nurses to all countries. It's because they're paid in pounds, dollars, euros. And India, still being an advancing country or a developing country, finds it difficult to match up those salaries, and hence we do not try to stop. And the doctors go to the extent, either you stop my qualified nurse or you give me an equally competent and ready nurse as of yesterday, otherwise I'm going, I'll stop operating, I'm resigning, I'm leaving this hospital. How many times we would have heard those words? And all of you would say that you would have come across such situations when your trained manpower is being taken away. So why attrition? What happens? Why do nurses change jobs? Why do people leave us? Attrition is very high in India. In the private sector, attrition is as much as from 30% going to about 70-80%. Ms. Usha Banerjee from Apollo Group spoke this morning. She has about 70% attrition in the Apollo Group. The attrition is also very, very high in the metro cities where opportunities are too many. In the smaller cities, people may be more stable, competition is less, poaching is less, opportunities are less. So where do people go and why do people go? Do you think people go only because of money, higher salaries, a little more thousands added to their salary? Is that the main reason? Some response from the audience? That's a reason, youngsters? It is one of the reasons. That's what the leaders sitting in the front row say, but it is only one of the reasons, believe me. It is not the topmost reason at all. All studies done in India, studies carried out in other countries have proven salaries are somewhere on the 5th or 6th reason why people make change of jobs. So what are the reasons then? Reasons is, first of all, do we really recognize and reward the nurses appropriately when they are within the system? Do we actually connect with our teams? Do we know our teams? How many of the nurse managers know the 250 or the 300 people working in her hospital? Are they married? Are they unmarried? Do they have children? Are they staying with families? Are they undertaking a higher studies right now? Are they going through a specialty course outside? Are they going through an illness? Are they having difficult times? Was there a death in the family which has disturbed them? How many of us make that effort to connect with our teams, with each and everyone in our team, and to build a culture of trust that the teams know you and you get to know your teams. If you do not have that connect, you do not know your team, you do not recognize your team, you do not acknowledge what they do. We walk through, as nursing leaders, we walk through the departments, we look through our team. As Dr. Reddy mentioned that do not talk to patients, talk with patients. Similar way, do not talk to your teams, make them participative in everything you do. Somebody in the morning was mentioning about setting up protocols, setting up safety protocols, setting up processes. We seniors, the nurse manager, the deputies, the supervisors make some procedures. Tell the nursing team, here, this is your procedure, you will follow, and I want it to be followed. That's the end of the story. Imposing a protocol, imposing a process on the team, that to today's young generation does not work. Does it work at home? You tell your children, especially the teenagers or the grown-up ones, I have told you you'll be home by 6 p.m. Do you think they listen to you? Not at all. They might try to show that they abide by you. Same way, nurses in India don't say no. They obey. We just discussed, they are very obedient, they are silent people, they do not communicate, they do not say no. They'll say yes, ma'am. Believe me, when they have said yes, they have not even understood what they're expected to do. They have said a blind yes, because all we expect them to do is to say yes. How can they follow something? Do they have roadblocks? Do they have barriers? Do they really want to follow that? Have we come up with a process or a protocol after having a fair discussion with them? Was it a participative process or protocol? Why can't we have a culture where we have youngest team members from various departments and ask them to design a process? And if they design a process, if they are the ones who have designed, they will own up the process, the implementation be 100% without any orders. You will have everyone simply following it because that is something they designed it, they defined it, they'll be proud of it. Give them rewards, give them acknowledgement for defining and designing such an excellent process which brings more improvements in your system, in patient care, in safety, or whatever else you do. So make them participative. You have to acknowledge, you have to recognize, and you have to give a pat on the shoulder. We are excellent critics in healthcare system, whether it's a doctor, a nurse, or a nurse manager, or an administration. All we do is to critic. You have not done this right, you have not done this in time, why there was an error, why did you have a needle stick injury, how come you did not send the patient on time? We do that hundreds of times in a day with hundreds of people in a day. How many times do we walk around, we sit down at the patient care areas, we watch them doing their jobs, how many times we get up, appreciate what they do, and give a pat on the shoulder and actually reward them for small things. Also, criticism as and when required will have to happen, should happen within closed doors. Appreciation should be done in public. We usually do the reverse order. We go to nurse areas, I would not say for now, times are changing, but what happened when I was a young nurse in the army, or even much later, we would have the matron coming on rounds and we would be so very scared and shivering because she would start screaming, shouting at the patient care areas or at the nursing stations. And we would feel so insulted and humiliated. Those were the olden times. But even now, many hospitals have the leadership style with dictatorship. The youngsters do not have a say in the matter, and if you don't have a participative style, you do not reward and recognize, you have not set in an open culture. So what is an open culture? How will it affect attrition? The open culture is everyone should have freedom to speak. If there is there's a defined protocol, there is a process which needs a change, which everyone is feeling the burden of doing that. There are unwanted activities in the nursing. There are activities which somebody else could take on. We should be open to making these changes, which will bring forward an open culture, a culture of change management. A nurse should have a confidence that this is the place where if I speak, I bring up a point, I bring up a suggestion, it is taken very seriously by the management, by the senior management, not just heard, it is also implemented, of course, after evaluation. That is the culture, if you could bring along, it adds a lot of weightage to the nurse. She feels valued. So one of the reasons why people would stay in an organization is where leadership recognizes and acknowledges them, where leadership or management acknowledges the efforts they have, and there is an environment of freedom, free speaking, there is an environment where there is happy culture, there is an environment where everything is absolutely inspiring. How many times in our monotonous routine we have motivational talks, or we have inspirational talks, or looking at the nursing workforce, They're mostly ladies in the profession. Say about 80% are women in the nursing profession, about 15 to 20% are the male community. Ladies have to have a work-life balance. They need to manage work, they need to manage family, they need to manage their own studies, their commuting, their in-laws, their parents, childbirth, the pregnancy period, a newborn baby, a ailing mother or ailing father-in-law. And with so much of pressure, the stress is building up. So how many times do we engage with the team, and how many times do we make efforts to relieve them of the stress? How many times in the hospital, considering it's so much of stressful environment, it's a stressful profession, and there's so much of added burden every day with multiple reasons. How many times do we engage positively with the team, and we have forums where stress management can be taken on. We have forums where you could have a counselor for the nursing, not a mentorship program just for the knowledge and the skill building, as Josephine mentioned in the morning. But we have forums where people can openly go and have a chat with the counselor, a psychosocial counselor, where they can sit down, they can chat, they can come up with the problems, and that needs to be absolutely a confidential forum, because people would not like to come up with their problems and the problems be discussed openly in the hospital. Again, we are on the reasons for attrition. So work schedules. In the nursing, we are very fixed. There is a morning duty, there is an evening duty, there is a night duty, and there is a general duty, and that is the end of the story. If you were to look at, or if you were to think of flexi duties, how many times the administration or the nursing leadership is open to flexi duties? We are not. Because there is a certain culture for last 3 decades, 4 decades, we have heard that is how we function. Time given to me is 5 minutes. That's being unfair. Somebody else has taken my time, but okay, I'll take about 7-8 minutes. So you need to consider flexi duties, considering the typical situations under which the nursing team functions. As we discussed, overwork, lack of role clarity. I was hired to be a cardiothoracic nurse, but for some reason I have been posted to the labor room. I have been hired in the OPD for last 2 years, and I'm not being moved to a specialty area. I've got aspirations to go to the US, where I require a ICU experience for 5 years. I'm not feeling connected with the hospital. I'm not receiving any respect and contribution. The doctor shouts at me, my nursing supervisor shout at me, and the administration always rebukes me, and my salary is cut, my days off are cut. These are the reasons for people moving away. So here we're coming to the consequences, how it impacts safety and how it impacts quality in the hospital. Losing these critical employees definitely lead to decreased quality of patient care. Whether patients are in the procedure rooms, patients are in the operating rooms, in the intensive care areas, or patients are in the general areas, the quality of care definitely goes down with increasing attrition. Loss of patients were discussed. Increasing contingent cost because of accidents, also because of more overtime paid to the people. You call people, they are doing double duties, you need to provide them lunches, dinners, extra money, the overtime money. Increased turnover definitely displeases and makes your medical fraternity unhappy, because their time is very expensive, their time is very valuable. As we discussed, you could have physician assistants, you could have nurse practitioners, you could have coordinators for various specialty programs, and that can reduce the doctor's burden. So if your attrition is really high, these quality initiatives cannot be really taken. Increased staffing cost because, as we saw, cost of losing one nurse leads to about 3 times the salary of her. So if you've lost 100 nurses in a year, imagine the amount of money you would have lost. And in Columbia, Asia, we carried out a study on what is the cost of losing a nurse. And I just saw the figures during the annual reviews. The cost of losing a nurse was coming about to be 4.5 lakhs. Do you want to think of adding half of that money to her salary? How many hospitals will agree to adding that much of money to the salary? Hardly any, unless they see it objectively. Increased accident and absenteeism. When a nurse is too busy, she is not looking left and right. She's running with the injection tray. Either the injection falls down, or the tray falls down, or the nurse falls down. We see those very, very often. So this was the main, how does it impact patients? It is impacting, it leads to high mortality rate. It leads to increased hospital-acquired pneumonias, increased hospital-acquired urinary tract infections, septicemias, nosocomial infections, pressure ulcers, patient falls, shock. The nurse has not been able to monitor a patient or to do a early warning score, and the patient has already gone from a bad to a worst condition, and leading to shock and maybe cardiac arrest. Medication errors, all of us know, are on the rise because there are not enough nurses to either verify medicines or to look at the infusion protocols, or also to look at the post-medication effects on the patient. Couple of studies I had put here. So this is a data, if you can read through, a study of this data for more than 10,000 nurses and more than 232,000 patients discharged from Pennsylvania reported a relationship between nurse to patient ratios and preventable death. Imagine, for every one surgical patient added to the nursing workload, the odds of a patient dying were increased by 7%. That is the value of having adequate numbers. Another study, this was an Australian study where death rates decreased by 25% for all medical surgical patients. Surgical patients experienced a 50% drop in complications in central nervous system. 30% faced a decrease in gastritis and upper GI bleeds because of timely monitoring and timely escalation of the early warning scores. These are a couple of other studies which are done on the nursing workload. There was a study done by Dr. Rajan in India. Even I have that with me. This is a Canadian study. This is another US study. So research continues to show that nursing overwork and poor environment leads to these factors, leading to impact on the quality of care and on the patient safety. I'll show you the Indian study since time is less. Okay, this is an Indian study. Dr. Rajan from Kamaraj University in Madurai conducted a study, and this was impact of turnover on the hospital performance. Excessive workload for remaining staff, delays in daily routine of procedures, whether it is transfers or monitoring in the ICU or in the wards, absolutely poor patient satisfaction, complaints from patients take a longer time to resolve, poor job satisfaction of the remaining nurses because of the sense of not achieving what they should have achieved during the day, complaints from doctors, complaints from other departments because work has not been done as per the required expectations. More wastages, hence more financial impact on the hospital, increase in recruitment cost, increase in training cost, impaired patient safety, high stress, difficulty to manage the hospitals. I know of hospitals which were constructed, which were built up and were lying without commissioning or opening. I'm talking of brand new hospitals in Indian setting because they could not hire required number of specialized nurses in that hospital. Hospital remained unopened for more than 6 months, and the cost of keeping a hospital with air conditioning, with the equipment installed, was about 2 to 3 crores a month. So what is the impact on that hospital for 6 months? They've already lost close to about 20-30 crores of rupees because they could not hire adequate number of skilled nurses. Impairment of the reputation of the hospital, impaired quality, low level of efficiency, low motivation of nurses. Nurses would move away if you do not have adequate numbers. You've already lost 50 nurses out of 300, so 250 nurses are doing the job of 300 people. Believe me, another 50 will find their way out in the next 2 months because workload is so high and we do not know what is happening. The nursing leaders go into a state of shock. We must look for models of assigning nurses that addresses the workload. We need to look at fairly decent salaries because in today's world, everything is expensive. Cost of living in smaller cities is also very, very high. Nurses come from various states. They need to take a place for stay if they're staying with families. Hospital leaders need to look at the value of having a dynamically changing salary band for the nursing. You need to look at an excellent training and development program to take them up to a level where they are able to function with confidence, conviction, without fear. You need to empower the nurses, truly empower them to be able to speak to a doctor or to an administrator when something is not going right. We recently had a JCI visit in one of our hospitals in Bangalore at Columbia Asia, and the JCI and shouts the nurse should have a code which she can activate, and somebody from the administrator, a manager level person or a team of people can come forward to resolve the problem on the spot then and there. I seriously like the idea of having a code when a nursing empowerment is questioned and when a nurse does not have enough freedom and authority to handle a situation. Train the nurses on decision making. Let the nurses not go through the hierarchy of an in-charge nurse, a supervisor, a nurse manager, a chief of medical services, a chief of nursing services. If something is not right, the nurse should be trained and should be empowered to escalate it to the highest authorities, even to the chairman of the hospital without fear. How many times do we appreciate a nurse pointing out to the doctor, "Doctor, you have not washed your hands properly," or "Do not touch my patient because your hands are not clean." At the most, what an infection control nurse or a ward nurse would do, she'll pick up the hand rub and offer it to the doctor, who shoves it away and gives her a look that my hands are sterile. How dare you offer the advice to me? There was my infection control nurse who pointed out to a registrar, "Doctor, your fingernails are very dirty and you are going to do a dressing. These nails are long and dirty, will tear off the gloves. You go and cut your nails first." It was talk of the town in the hospital, at least for that day. The doctor was unable to accept that. But fortunately, I'm in an organization which is with a Western culture. Ours is a US managed group, and we have a Western culture. We have put across a culture where the junior most nurse can point out anything to anybody. We do not have closed doors, closed offices, and we have fired senior team members because they were rude or abusive to the nurse. That is the kind of empowerment in the Indian context we need to give to the nurses, that do not fear truth. Be an advocate to the patient. You know your job right. Do it right. After that, we are there to support you. Do not fear pointing it out to anybody when it comes to patient safety, when it comes to quality of care, when it comes to somebody breaching a protocol. An instrument has fallen down from the OT table. You have the single instrument. The doctor says, "Doesn't matter. I'm in a hurry. I can't wait for a flash sterilization. Put it in Sidex for 2 minutes and give me." Believe me, it happens in the operation room so many times. Because the doctors have the aura over the nurses. The nurses, although she knows it is an incorrect protocol, still will put it in Sidex and wipe it and hand over, and a patient ends up with the infectious implant, a orthopedic patient, and you have to remove the screw or the implant. If the nurse was confident enough, was empowered enough, she would say, sorry doctor, but we got to wait for 9 minutes because it takes 9 minutes for me to at least have a rapid sterilization and a flash sterilizer. That is the clinical empowerment and administrative empowerment you need to do to nurses so that they feel important, they feel needed, they feel valued, they feel their knowledge and skills are coming into practice truly. We were discussing the syllabus, the curriculum in colleges, nurses are not ready, they have to go through a mentorship program, all that is taken well. After all that is done, have we truly given them the freedom to practice? Have we given an autonomy of practice to the nursing leader? Does she have a say in the decision making, how many people she will hire, how they will function, which department they will work? Does she have a true autonomy in deciding the nursing salaries? No. She says, I want 20,000 startup salary. The administration says, sorry, we are not making profits. I can only give you 12,000. So if you pay peanuts, you will only get monkeys. How do you expect an excellent job in a hospital, a truly satisfied and accomplished, efficient nurse, leading to minimal attrition and excellent patient care and safety, having enhanced image on patient care, not just nursing care, and having a absolutely super image of the hospital if you do not have all these ingredients put right in the dish which you are making. These are all the different components which make it. I will stop here. I've got a couple of other studies which Josephine in different forums can take on with the team. But my lasting message to the youngsters sitting here who impact the attrition, you need to just remember a few things. You are probably justified in making your move to another hospital, another organization for your growth, for your development, for higher salary. It should not be at the cost of a patient not having the right nurse-patient ratios. So what does that mean? That means you need to have a moral responsibility of giving an adequate time to the hospital so that the hospital can recruit your replacement, also have a basic induction done for the nurse, and that nurse reports into the department from where you are exiting. Thanks to the Indian Nursing Council and no thanks to the Indian Nursing Council, there are no nursing bonds in the country anymore. What has that done? A nurse takes her salary on 1st of the month, which comes to the banks nowadays. On 2nd, she does not report for work. A nurse comes today with a visa and a ticket for Dubai. I need to fly day after tomorrow, do my clearance tomorrow. A nurse comes today, I'm sorry, I will not be able to come from tomorrow. A nurse goes home for a 3 days leave, sends a email that I have found another job. Is this moral responsibility by a nurse? Is this professional behavior? How many doctors, how many other healthcare providers, responsible professionals do you see who leave their job in 24 hours notice, who leave their job without a notice period? That means you yourself do not value your job. The hard reality, the grim reality is you do not value your job. You think there are 300 nurses, how does it matter if I don't go? You don't value your position, you don't value your work, you don't value your place in the organization, hence you are also not valued back. We had the debate, my last words, we had the debate on are we fit to be on the driver's seat? Somebody said we are already on the driver's seat. Somebody else said, why demean us by calling us drivers? You can be called pilots. Pilots are drivers who fly the planes. To be on the driver's seat is an excellent feeling because you have the power to take the vehicle in the direction you want to, with the speed you want to, and with less accidents, less injuries, and in the safest manner. We want all of you to be that quality of driver let me call pilots. So that quality of pilots who believe in an excellent journey for your patients, for yourself, and because you are in the same vehicle. If you are in the healthcare, you need to add value to the healthcare. So please be the one to add value to the hospital you work. Make a place for yourself. Let people remember, okay, Josephine was an excellent nurse. She made this change in Continental Hospital. Ajita was an excellent nurse. She made this change in the Fortis Hospital. Each one of you will be remembered and valued for the good things you do. For the bad things, we won't even remember your names. Be the one to leave behind a pathway with your footprints to be remembered forever. We remember Florence Nightingale today. Why can't we remember each one of you who is the true follower of Florence Nightingale? Thank you.